Welcome to DeBakey CV Live. This is the first episode of what we refer to as Aortic Talk, a series of talks, webcasts and podcasts around aortic topics. I'm joined here by three people, going from far and near. Dr. Tom MacGillivray, he's the Chief of Cardiac Surgery and Thoracic Transplant here at Methodist DeBakey Heart and Vascular Center in downtown Houston. Next to him is Marvin Atkins, and he's the Chief of Cardiac Surgery at Methodist Sugarland. And the guy who's really going to provide the entertainment for the evening is Chinnadurai. He's a senior research scientist with Siemens and the guy who makes a lot of this work. Well, welcome.
Thank you.
Thank you.
Ponraj, we're going to turn it over to you. And you're going to tell us about image fusion techniques in the hybrid operating room.
Thank you very much for the intro, Dr. Lumsden. I feel very privileged and a little bit nervous to be sharing the podium with the stalwarts like you guys. Working with you has been a pleasure for the last few years. And hopefully I'm going to bring in a different perspective on how we have used imaging by being in the field for hybrid operating room aortic procedures. So let me kick off with my obvious disclosure. I'm a research scientist working with Siemens, but I work here in Houston Methodist. And just to kind of set the stage, as you all know, I don't have to preach the choir here. The aortic procedures or aortic disease in general has been conventionally been treated with open aortic interventions or surgeries, and now endovascular options are coming along. And what started as standard EVAR and fenestrated EVAR to branched EVAR, now we are looking at technologies from device companies for aortic arch and even ascending aorta for type A dissections, for example. So eventually we would be at a point where we could potentially do, in theory, endobental for these patients, given all the device and imaging questions have been answered. So that's kind of how I want to set the stage.
Should we thank Gustavo Godrich for these beautiful pictures that you've got here?
Anytime
Thanks,
we see these illustrations, it's definitely a very clear learning sketch that Mayo Clinic has been grateful to provide us with all these graphics, which really helps understand how these procedures and devices work. So now I'm going to talk a little bit on running two tracks, and this is one of the things I feel privileged to play by being on the field, is understand devices and understand imaging. And how, I know Dr. Lumsden, you can share your story.
Let's get the other guys involved. One of the issues we've always had is there's the imaging companies and then there's the device companies. Right. And I always felt there's people like us in the middle of them saying, you really need to be talking to one another. What's your experience?
Well, I mean, obviously it's determined at the location, the expertise of those who are helping out with the imaging in that hybrid operating room suite, what they're able to provide in terms of markers to help you with your endovascular procedure. Really is just the gamut of how experienced those folks are in the operating room.
Yeah.
It's been my experience.
So Marvin, why don't you tell them a little bit about your training briefly? If we've got time, we may get into this in more detail, but you obviously come from a very different background from the rest of us.
So originally started off as a vascular surgeon, was in practice for about 10 years, and then actually made the conscious decision mid-career to go back and do cardiac surgery, and so finished up a 2-year cardiac surgery fellowship at Penn.
Has your wife forgiven you yet?
We're still
working on it.
Talking terms, fortunately, but yeah, it really provided a nice open and endovascular background and experience in both, and be able to provide both options for patients, and gives you definitely a different mindset when you're looking at aortic problems.
So that's definitely one of the interesting backgrounds to have, and one thing at least I've observed by working here at Heart and Vascular Center is aortic disease is such a continuous spectrum of disease, so we really need to put devices and imaging all together to solve this problem. So I'm sure, Dr. Lumsden, you can recollect your days in Emory where we have done complex procedures with mobile C-arms, and we have come a long way in you bringing up, the imaging has evolved so much from plain old 2D angiography to 3D cone beam CTs and multi-modality image fusion guidance. So what I'm going to talk about here is how we can really enhance fluoroscopy, which kind of has been there since like for years and decades, how we can enhance that, because one of the common limitations is it is a planar imaging. We don't have depth, so we are trying to see how we can bring the third dimension and possibly the fourth dimension to these 2D images.
So let me ask Dr. MacGillivray, I mean, you got a leadership role in the SDS. At the present time, if you're going to do cardiac surgery, what is imaging built into the training program at all, or should it be?
It's essentially a supporting actor. The presumption is that you understand imaging, you know how to interpret it, and you can bring it to the bedside or into the operating room. But I was going to say, in my professional lifetime, the greatest advancements in medicine have been in imaging. I've gone from M-mode echo to plain X-rays and essentially angiograms. And then you'd have to take these two-dimensional images and in your own mind shape them together. And some people were better at doing that than others. And now the imaging we have today, I mean, it's extraordinary. You see with the images what you see at surgery. And so I think that, in my opinion, the advances in imaging have outpaced our ability to teach imaging and for trainees to learn
great
imaging.
way of putting it, yeah, so one of the things, because we're obviously interested in dynamic imaging, and one of the analogies we're trying to use is, nobody will ever come to you to fix a mitral valve and show you a static image of the mitral valve, and yet we take aortic dissections and the standard of care is you get a static image of the aorta. Right. And we're trying to say that we should be applying the same kind of standards to particularly a really complex dynamic structure like a dissection that we would think of when treating heart valve. It's a functional problem, maybe not quite as much as a valve, but nevertheless.
But that's what, it's, just a decade ago, the big part of cardiovascular surgery was you use the imaging to make a diagnosis. And then a big part of the thought process would be figuring out what you might find at surgery and have a plan to deal with whatever it is that you found. Now we have the ability to sort that out before you go to the operating room. It's essential before you go into the endovascular suite or the hybrid suite to know exactly what you're dealing with. And I have to say, it adds a big bonus to the open operating room as well.
I mean, think about intravascular ultrasound, especially in the setting of aortic dissection, just how dynamic that flap is and how often that can change your plans when you're looking at patients that have mechanisms of malperfusion and trying to sort those things out intraoperatively. It would be great to use imaging beforehand, before you even got to the operating room, to figure out some of those things in a dynamic level as well.
So that's kind of historically been addressed by radiology or imaging departments in general. So we do still a good job of getting diagnostic imaging, and that's kind of what I laid out in this slide, where we are talking about diagnostic imaging, which is kind of run-in-the-mill scenario where we get a good images. But what, in my opinion, is often the gap that I feel is when it comes to intraprocedural imaging, we are still limited to 2D imaging capabilities, or even ultrasound, for example, can give us 3D data, but there is no common framework to stitch all the data together. Currently, it is completely reliant on the surgeon or the interventionalist, who is up to him to put all these data together. And that's kind of the goal we are working towards, to see how we can create a common framework to provide better image guidance, not just for endovascular procedures, but also for open surgical interventions. So, and that's kind of what I kind of laid out the technologies here. I'm not sure I'm going to go through each one of those, except for the 2D, 3D, and 3D registration. And some of the potential technologies out in the horizon are like shape sensing technologies, can help us not just know the location of the tool tip, but also the entire catheter shape can be inferred in 3D. So then we don't really need a lot of X-rays to understand all these complex stent grafts, for example. So I'm going to focus mainly on intraprocedural image fusion, and I'm sure there are going to be a series of talks in this series on diagnostic CT and MR imaging, which our team here can speak for. But what I'm speaking for here is how we can take that data as it is today and use it for surgical interventions. And I'm going to start off with one of our cases that we have done recently together. It's a 68-year-old male who had a prior type B aortic dissection, and on follow-up CT imaging, he was found to have enlarging false lumen. And I'm going to go through some of these aspects as a live demo by loading some of these CT data sets into a post-processing. So I'll come back to this device. So this is a device that we are planning to deploy in this patient, which has a branch to the left subclavian artery, so that way we have enough landing zone. So I'm going to quickly toggle to the CT data set.
While you're doing that, let me say one of the things I neglected to mention was that you're a physician. Yes. You're a physician who has chosen to focus his career on imaging, and so it's very helpful in talking to you about a procedure that you've got that kind of medical background.
So the way I see my role is, I mean, when it comes to technological jargons, there's always a lot of technological jargon. So what I essentially do is translating the technological solutions to the clinical need that I see in my own eyes on a daily basis. So there is no like, okay, this will be available 5 years later. Like, it is something that I need to do today. So, and that's kind of what I take up as a challenge on a daily basis. So image registration, often people think of it as a complex technical solution, right? But it could be useful even in your clinic. For example, if you're seeing a patient who has a series of data sets or imaging follow-ups, and we often look at one monitor, scroll through and find the ascending aorta or SMA, and then go to load another study and then find the same level. And that's standard of care today. So what I'm going to try to demonstrate, hopefully it works, is, for example, this patient had a CT study from 2018 and 2019 that you're seeing here. I'm going to try to select both the studies and say, okay, I want to compare using this one of these workflows. So what you can see at real time, what happens is, so the algorithm knows where exactly the known anatomical landmarks, such as clavicle, sternal notch, iliac crest, and then it tries to put it all together and match it. And what you're seeing here is it's trying to load the data set right now.
So you're doing this real time.
Yes.
This is not a PowerPoint presentation.
No, I've
this
not.
is real time working with these images.
So what you're
You're
seeing,
a brave man.
well, so what you're seeing on the left, or when it says current, is today's time point, or October of last year, and this is what you see on the right is the prior study from 2018. So what I'm going to go through a time point here.
So this would be a patient you're seeing back in the clinic that has an aortic dissection that you're following chronically. You're trying to see if the lumens are enlarging.
Exactly. And it's, when it comes to measuring sizes of these aneurysms, it's often critical because we are set with a certain threshold of 5 centimeters. So we want to make sure we are measuring at the right level. And that's how we are trying to use the imaging to kind of like, so what I did right now is match the 2014 study. So right as I load it onto the scan here, so you're looking at a 2019 scan and 2018 scan. The software automatically matched. You can see the pulmonary artery is matched. And as I'm going down to the descending thoracic aorta, as you can see here, this is the true lumen and that's the false lumen. The false lumen is definitely increased in size. And it's thrombosed, but it increased. And as you go down, you can still see some flow in the false lumen more towards the, so there is an entry tear or there is a fenestration there.
So with these two data sets, what do you tend to use as your anatomic landmarks to mark them as at the same level?
So this is done completely automatically. I can readjust it if it is off, but it seems pretty close even by looking at the shape of the vertebral level.
If not, you use the PA bifurcations, or you use bony landmarks? Or?
So more often I go by vascular landmarks rather than bony landmarks. So I go by ascending aorta, top of the arch, and then aortic bifurcation. These are the known landmarks. We can reset it, but very rarely I have to reset it because this is not on top of fusion or like 3D fusion. This is more of a side-by-side visualization.
Sure.
So here, this is one way of very quickly assessing in multiplanar views as well. So here you can see the software automatically found, because one of the study that was done in 2019 is a full chest, abdomen, pelvis scan, and the study from earlier was just chest CT. So, and it automatically knew where the landmarks are, and as I'm going down to the abdomen infrarenal portion, there is no data for comparison. As I'm coming down to the arch, now we have the data.
So Paraj, can I ask you a question? Frequently we see patients in the middle of their course. We are having images that we take at our facility and have to compare them with images that were taken in another facility.
Yes.
Does the software allow you to match them as well if they're done in different machines?
That is a very valid question. More often we have patients come with their own CDs from outside scans. So as long as it is a DICOM data set, it doesn't matter which vendor, it doesn't matter which type of scan. As long as it's a DICOM data set, we should be able to load it in 3D and do these kind of comparisons.
If they're different slice thickness, how does that affect it?
Still. So for example, if I zoom in these two scans, say at the level of the ascending aorta, for example here, you can see, I'm just making it bigger so we can see it better. So you can see the difference in the outline of the ascending aorta, for example, right? So this one is EKG gated, the one on the left, and the one from 2018 is an outside study, and you see how the stair-stepping artifact as I zoom in, right? So this is different slice thickness, but again, we are going by the anatomical landmark, so it still kind of matches them together.
And just to clarify, this is all done on Syngovia.
Yes.
Correct?
So this is all done on Syngovia, and I'm doing it real time to show that how easy it is to load those two data sets and let the algorithm take care of the comparison part.
Even easy enough for surgeons to do?
Yes, eventually.
Remains to be seen.
We're not the most patient lot.
Yeah.
That's our goal. Most of these tools are historically been built for radiologists who are reading these scans, but eventually we want to get the imaging to the end users here, in this particular case, surgeons.
This would be a
to be able to-
no-brainer to use in the clinic.
In clinic,
Yeah.
and you'd use it every week.
So, and the reason I wanted to start this with this is still image registration. So people tend to think image registration or image fusion is something you do only in the OR, but this is essentially the same algorithms that are putting these two data sets together. Here is an example of 3D to 3D data set mapping.
Okay. Although we're asking all the questions here, there's also an opportunity for you to ask questions. And so it's, if you text DeBakey, DEBAKEY, to 37607 if you've got questions for Ponraj or Dr. Atkins or Dr. MacGillivray, please feel free to send them in.
And then we'll direct him to Ponraj.
Yeah, probably.
So one thing we looked at the comparison, and now we knew we need to intervene on this patient. So one other thing is specific to thoracic endovascular aneurysm repair or aortic dissection. So we have certain workflows. So here we're looking at a CT vascular workflow. So what I'm trying to show is the software automatically created the center line of the aorta, and now we can go ahead and measure the landing zone. So one thing, if I show you in the coronal, in the candy cane view, is a direct origin of the left vertebral artery coming from the arch, and that's the left subclavian, left carotid, and right innominate. So what I'm trying to show here is study the landing zone, and this is relevant because for the device that we pick has to have enough seal zone for us to make sure that we don't have type 1 endoleak, and I can show that in 3D image here. This is kind of the anatomy that we are looking at. So, and in this particular case, I'm sure Dr. Lumsden and Dr. MacGillivray, you have done this plenty of times. So what we ended up doing is reimplant and transposition the left vertebral and into the left carotid and do a carotid subclavian bypass. So that way we gain all these landing zones. So we want to make sure our device lands right where this green disc that you are seeing here. And because we have center line, and these devices tend to not follow the center of the aorta, like more on the outer curve, we can also do an outer curve measurement, which will probably help us better with the length of the device. So for example, certain devices come with certain lengths. For example, in this particular case, we can get a much better assessment of the landing zone here. And this is, again, even though we are talking about automated processing, there are certain things like driving a manual car. We also need to know how to shift, right? So for example, one of the most key things is to learn imaging is how do you familiarize yourself working with multiplanar views, like what I'm talking about here. Dr. Lumsden, maybe you have learned this over the course of the last few years. Maybe you can kind of pitch in a little bit about how critical it is.
I mean, I go back to the analogy we used to get. It was one view is no view, and you know the example somebody pimped me with once was a chest X-ray which had a big lesion in the left lung field, and then they showed a lateral X-ray and a lateral picture because they said, "What's this diagnosis?" It said it's a melanoma. Well, wait, that was a little surprising, but on the lateral X-ray, it was a melon sitting on top of the patient's chest. It wasn't in the lung field at all, but it kind of emphasized, I never forgot about it because it emphasized that one view is no view. Yeah. And here, when you've got this 3D DICOM data set, you have every view you could possibly want to see. And then if you can then add on the dynamic components of it down the line, you know, that's the value. And you know, I do think endografting had a major role in the development of people working in NPR because it was necessary working in the infrarenal aorta and then up in the visceral segment to make these measurements appropriately and accurately, and that led us to start working, you know, in this NPR field.
Okay, so So basic multiplanar reconstruction and centerline measurements are often the first steps in planning the stent grafts. So I'm going to go back to finding these measurements, and also the next thing is optimizing the C-arm angulation. For example, if you are shooting an arch angiogram, the conventional teaching is, okay, let's go to LAO 45 and shoot the angiogram.
Right.
So for example, I can go to LAO 45 in this particular patient, and then we can see how much optimal or suboptimal that view is. So what we could do is, because we have all these 3D data set in our hands, so what I'm demonstrating here is how we can work in multiplanar views and come up with two rings. So once you have marked the vessel ostia of the left subclavian, and in this particular case, left carotid, and the ring for the aorta. So once you have two rings, which is kind of what I'm showing here, so here you have the two rings, and at the left carotid. So
there we understand. This is, you're not even in the hybrid room yet.
Yeah.
This is all done preoperatively. We usually do it in the control room, but it could be done on a workstation at any time prior to going into surgery.
So what this picture demonstrates is how you can draw these two circles, so then you reduce the problem to simple trigonometric problem. It can be only two views if you have two rings. Either you can see it from the front or you can see it from the back. So if you're trying to see it from the back, the C-arm cannot really mechanically go to that position. So when you see the C-arm graphic here as blue, then this view is achievable. So we knew walking into the procedure that these are the views for the landing zones, for proximal and distal landing zones, and that's all planned. So now we kind of have a better idea of what size device to use, what length, and what angle of the C-arm that we need to use
To be
to
totally
deploy.
perpendicular to the vessel.
Exactly. And that is often critical because we don't want to jail or occlude any of these branches.
Right.
But even then, sometimes you have to compromise a little bit, and the best example is we want to see left renal. But the best angle sometimes shows you on the CT scan that the SMA is lying right on top of the origin. So you get the best angle when you shoot dye in it, and the SMA pacifies it. And so you can see that on the CAT scan, and you can move the SMA off by changing the orientation of the image intensifier. So it saves you time, and it saves you dye, and it saves you radiation.
Okay. I'm going to make a comment here. So when it comes to these angiograms doing in the OR, if a patient has already got 80 to 100 cc's of contrast to get a 3D image, and it's kind of like a map. It's like venturing out without taking the map that we already have. So if you are going into the operating room and shooting an angiogram sort of blindly and kind of, oh, that doesn't look optimal, let's just go a little bit more LAO, and then shooting another picture is probably something we shouldn't be doing, given that we have all this technology to derive that angles for us.
Makes sense.
So, okay, now kind of we are at this dotted line where we did all our planning before the case. So the case is now happening in the OR. Now we are getting into the OR. So now I'm talking about how we integrate all this nice preoperative planning to what we are going to do in the OR. In this particular case, an endovascular procedure, which is a branched endograft deployment. So then all this information that we just talked about has to be linked to the C-arm. And that is achieved by the process called image registration. So image registration is kind of a technical term, and more a colloquial term is image fusion, which could be more like putting together any two data sets is image fusion. So image registration can be broadly, this is again a very broad classification, where we can take two routes. One, by creating another 3D scan in the operating room, like with the video I showed earlier. So that is done without any contrast, and now you can put two cubes together. By cube, I mean the CT that was done today in the operating room, or cone beam CT, and a pre-procedural CT that was done the day before or the week before or a few months before. And you put that two together. It's kind of like matching the two cubes. And then we know exactly how the patient is lying on the table, and when the C-arm comes in, and when you step on the first fluoro image, you know where the vascular landmarks are without even injecting contrast. And that's the advantage that we are trying to do. And the second approach is by 2D, 3D registration. So here it's a bone example, but if, for example, in this case of a femur, for example, you can take two views and derive, like kind of triangulate, just like how our GPS systems triangulate our position from data from two satellites. So you can triangulate your position of how the patient is lying on the table by acquiring two views. And that's kind of what I'm showing here in two examples. So this is a scan that was done CT, and the scan was done in the OR. And here we are matching based on the wall calcifications. and all these rings that we talked about, that we drew before, shows up on your angiogram. In patients who have prior hardware, like a prior stent graft, in this particular case, we were re-intervening for a type B dissection to put some coils in the false lumen to block the residual flow. So we can use all these existing hardware and
So you mean take the image of the endograft
Yes.
from Mrs. Smith a month ago, and the image of the endograft you've just created, and put the two endografts together.
Yes.
Now you're fused.
That's
Pretty-
instead of repeating another, doing another 3D imaging, because we have the hardware, we can do that. So what if there is no endograft, and if we want to do 2D, 3D registration? So we can put in our own hardware, which in this particular case is a stiff wire. We put those stiff wire mainly because we wanted to make sure how we simulate how the delivery system of the device is going to deform the aorta. So what you're seeing on the right is a fluoro image, and in the background you will see this the wire. You can kind of see it here in the lateral view. And because we are doing vascular registration, we are not matching the spine, because the patient's arm position can be different with CT, because in CT the arms are always up, but in the OR the arm position can vary. So we are deriving our own aortic fiducial by putting in wires and doing the registration.
So you put a stiff wire to the outer curvature, and then you match the preoperative CT outer curvature to that stiff
Exactly.
wire.
Yeah, we want to make sure that the wire goes all the way and hits the aortic root, so that way it hugs the outer curve and it's not flopping in the aortic lumen. And that is kind of your landmark, which is kind of what I'm showing here, to use that as a way to kind of fuse the aorta. So these are two techniques. There are certain cases where we use 3D approaches. More often, the 3D fusion tends to be more accurate, but for 2D, 3D registration, if you already have prior hardware, like PVL closures, for example, or prior stent grafts, or if you put in wires like this, you can still achieve closer accuracy to these.
Okay.
So this is kind of the link between the pre-procedural CT to the images we are generating in the OR. And this slide is key because this is where most people often struggle to get to the fusion process established. So what you're seeing here is, what you see in white is the 3D scan that was done in the OR, and what you see in yellow is the pre-procedural CT, and those are kind of matched together. So once they are matched together, this is kind of the link has been established. So these are the rings that I was talking about for the left subclavian, left carotid. This is our intended landing zone. And as you can see in our very first angiogram with the stiff wire and the pigtail, we are able to map it onto the fluoroscopic image. And as you can see, it's a little bit off here. So that's the left carotid. And you can see it's off maybe by a couple of millimeters. So, and you can re-register at this point. And for example, if the deformation has happened with the delivery system, you can stop, take a moment, do a quick puff of contrast, and then re-register. So this takes hardly 15-20 cc's of contrast. Then if you didn't do any of these things, you're going in there, going with a regular LAO 50 or 30, and then shooting a picture. That's not optimal. You change. So you end up easily doing 2 or 3 angiograms before you even start the case. And this is an example of how the delivery system of the device coming in. And here you see the long marker, which kind of gives an indication of where the portal or the hole for the branch that should be more on the outer curve. And we are kind of using that because we know this is our view, LAO 54 and caudal 15. And I wanted to point out that if some people are even can derive these angles by guess, but you can guess the LAO RAO, but you can't really guess the caudal or cranial angulation. So this is an example of how we really optimized for the landing zone and the device coming in. And as I'm fast forwarding here, you can see how the device is kind of getting stuck right at the vessel origin here. And now we finally got our device over the arch.
So I have a question for you. So
Sure.
obviously when you put a stiff wire around, it changes the geometry of the aorta. Now you put a stiffer device around, that also changes things. How often do you end up having to shift your fiducial markers around?
So it really depends on the device. So again, I don't have enough data to show that this particular vendor device is stiff versus non-stiff. So it really depends on the device and the patient's anatomy as well. So I would say in 60 to 70% of the times, we often do a quick check. So most of our cases, we do our first angiograms, first aortic picture after the device is in.
In position.
And until then, everything is guided based off of the pre-procedural CT dataset. So this is our angiogram. As you can see, it's off by a couple of millimeters. And here you have the option. So this dial that here, you can see me kind of manually matching it to the aorta. Once it is matched by these extra 2 or 3 millimeters, so it might look a lot here, but we are in a higher zoom here. So it looks like we are moving it, but we are moving by 2 or 3 millimeters. Gotcha. And once you readjusted it, it can track with change in zoom and CM angulation. So, and this is an example of deployment of the device, and we do one confirmation angiogram, and then the device is deployed. So this is the pre-aortogram, and this is the post-completion angiogram, and we extended it by another 15 centimeter device. And one other thing I wanted to point out is, do you see these little dots in the descending thoracic aorta? Mm-hmm. So those are the origins of the intercostal arteries. So when we are deciding between, okay, we wanted to extend, but we want to make sure that we are not causing spinal cord ischemia, and that information we often cannot get by doing an aortogram. Some patients, you see those intercostal fills, but they are very small vessels, so the flow is not that much to opacify them. So we see them very well in CT. So that's another way of knowing where the intercostal origins are, so we can make a judicious decision on how much we wanted to cover to minimize the risk of spinal cord ischemia in these patients.
So during TEVAR procedures, you mark not only the brachiocephalic origins, you also mark all the pairs of intercostals all the way down.
And that's what you're seeing here as these
That's
dots.
great.
So and that helps us decide our landing zones.
On the fly.
Yeah.
So one of the questions we've got for now came in was, how important is fusion going forward? Mm-hmm. Is everybody going to be doing this?
The short answer is that's the end goal, and we have some rocky road, but that should not discourage people from doing this. So the way fusion imaging, I see it as 2 broad steps. First thing is very easy goal to achieve, optimizing our views. And that there shouldn't be no excuse for doing that, in my opinion, because the data is already there, and it just takes an extra few minutes to process the data and coming up with that angle. And there are so many third-party softwares, device companies even do these planning sheets. So getting that angle should be standard of care. The second part of doing the overlay can be a little tricky depending on which part of the aorta we are intervening. For example, in ascending aorta, looking at coronary origin, there is a lot of cardiac motion. Arch, a little bit, but it's manageable. Infrarenal aorta, not a lot of motion. So the overlay, which is the second part, is probably where a lot of learning curve is. So I would say for people who wanted to do this, let's start with optimizing the angles first, and for that you don't need any fancy hardware. If you have a Mac, there is an open source software called Horos, which you can download and do all this multiplanar rendering and come up with your views without even stepping into the OR. You know what all your angles for renals, SMA, celiac, and your brachiocephalic. So that would be my answer. Let's start with something small and kind of gradually increase our skill set to doing the guidance on.
Tom?
Because as I see it, Panraj, in open surgery, the surgeon can be a little bit lazy, if you will, because a lot of the manipulation can be done in the operating room, in the surgical field. If something's a few millimeters off, you can move it, you can reattach it some other place. In endovascular surgery, millimeters matter.
Yes.
And it's much better to sort that out prospectively, proactively. And that can make the difference between whether your procedure is going to work well, effectively, durably, or not.
That is a very valuable point you're bringing, Dr. MacGillivray. One thing is, I mean, it's often difficult for the mind to switch from when you're operating in one mode, and suddenly when you go to endovascular procedure, it's just not the first nature. And where I have hopes is the younger generation, when they're starting to do more and more endovascular.
You're not talking about us, is that what you're implying here?
Well, you have trained.
Speak for yourself. You must be talking about those guys at the other end of the table.
No, it really depends on how you train. When you start doing more and more open interventions, I mean, your world there is so dynamic. You make like split-second decisions by doing these open surgeries. Endovascular is not like that. You can take your own time, plan your case, and go ahead and execute your plans in the operating room. And that's where it's not it's not any comment against the age. It's more about how you gain your experience and how you open your mindset for imaging for these endovascular procedures. That's my intent behind that comment. And I kind of wanted to show this one slide. We kind of went through that case example of thoracic branched endoprosthesis, and this is another example showing it's an array of case examples. From most of these cases, I have had the privilege to be there and learn from these cases. So it's not just thoracic endograft, so it has applications on so many vascular beds. Aortic PVL closures, where you see the defects, for example, very well in CT, especially in aortic valve, since it is so anterior, it's very difficult to image that with echo. Mitral valve is a different scenario. In aortic coarctation, where here we are using our optimal plan, and I even included the C-arm angulation here. These are not often the angles that we derive by random chance. These are really meticulously planned cases. Right. So TVAR with MR datasets, so a patient who had renal function got an MR, and here you can see all the markings, and this is for crossing difficult CTOs, pulmonary valves. Venous is another vascular bed where MR fusion can help. It all started with intracranial work with neuro, where the image registration process is relatively simpler because of a fixed head. And we do, at least I've had the pleasure of working with one of the key experts in neurointerventionalists, where I learned a lot of these imaging, and now we are kind of trying to see how you can apply those concepts in cardiovascular space.
I think many people feel comfortable manipulating CT data sets, but not so much MR. How difficult is it with MR data sets to be able to come up with different angulations, put them into post-processing and fusion as compared to CT?
I'm glad you mentioned it, because I prepared a case for that. This patient actually got an MR, and this is MR of that patient. So again, one good thing with MR is it's dynamic. So you can, so this is the same aneurysm of that patient, the dissection of the patient. Here what I'm going through is stepping through different time points. And here you can see the contrast is in the pulmonary artery. And as I am fast forwarding.
Well, let me jump in this, because the short answer is it's exactly the same, okay? The longer answer is that when we look at MR data sets in the office, it's overwhelming amount of stuff. But if you get it, what is this? Is this a twist image?
Yeah, so this is a twist image, and these are all the series of images, right?
So if you I think of it a little bit like the twist is about as near CT-like in the presentation of it as you can get. So in other words, you and I can actually relate to it as opposed to some of these other images. So and it's dynamic.
Yeah. So, and that's kind of what I wanted to bring up is, yes, there is an extra layer of learning curve for MR datasets, but for the effort that we put in, we have that evidence in terms of getting the dynamic information, the velocity profile, and there is much more we can benefit from these MR datasets, and not just in terms of anatomy, but also in terms of flow.
So the downside is they got to lie in the scanner a lot longer.
Sure.
You can't give them gadolinium, obviously, if their creatinine's up, but we have a research protocol with ferriheme, which iron oxide particles that can be used to actually as a contrast agent, not contraindicated in renal failure. There was another downside. I can't remember what it was.
Metal. So if you have a prior stent graft, for
and example. Resolution is the other thing. It doesn't quite give you the same spatial resolution as a CT scan does. But it's getting better.
It's getting there. So we have much more fine, like some of our T1 Vibe sequences are like close to 1 millimeter scans. So it's getting very close to CT. Most of it is the know-how of how to acquire the scan and the ability to process these images.
Alan, so for your type B patients that you're following chronically, many of those patients are younger, you're worried about long-term risk of radiation, contrast. Are you following these patients with MR now?
Yep.
Routinely?
Fairly routinely, yeah.
Okay.
Okay, so I think this is kind of my take-home message. So why do this, right? So there are enough publications out there that it reduces radiation, reduces contrast, reduces fluoroscopy, potentially procedural time. But this is one of those things that, okay, it's most often people think that it's nice to have, but let me just go ahead and do this case, right? So, and that's kind of the often mentality is.
Sure.
So what we are trying to see is how we automate some of these things that I have shown you, and so that way a surgeon can load the data set and do most of these post-processing in an automated fashion, and maybe does the validation or cross-checking if that is accurate or not, instead of doing all of these manual. So eventually we're talking about enhancing the 2D fluoroscopy with three-dimensional information, whether it is coming from CT or MR. We can even get that information from ultrasound. For example, if it's a type A dissection where you see the information in TEE, because we can see the geometry of the TEE probe, that information from echo can be brought to fluoroscopy when you're deploying the device. For example, if you mapped your entry tear, for example, in echo, then you can use that as a guidance in your fluoroscopy space when you're deploying the device. So this really serves as I said, the framework for getting all the imaging data that we have from the diagnostic imaging to your intraoperative usage. So what else can we do with this?
You mean there's more?
There's more. And I'm going to quickly breeze through this. I don't have time to go through each one of these examples. And each one of these, I've had the privilege to work with the surgeons and define the workflow for each one of these applications. And there are not a lot of experience on these topics before. For example, a patient had an ascending pseudoaneurysm. I'm just going to quickly glimpse through this. This is a patient, previous CT, like 3 days later, there is an increasing contrast in the suture line where you see the contrast in the pseudoaneurysm. So what do? Instead of going and reoperating on this patient, we went ahead and did a 3D acquisition. And this is kind of us using the laser crosshair and a needle to target that particular sac. And all these colored rings are coming from the pre-procedural CT. And you can target the needle, and this is kind of one of those aha moments where you have the needle and you have the blood written back. And hopefully
it's either really good or really bad.
Aha moments.
Hopefully it's from the pseudoaneurysm, but it is not a aortic puncture. But we confirmed that by doing another 3D scan and confirming that the coils are not inside the aorta, but it is actually in the pseudoaneurysm. So this is a 3D acquisition, like I showed in the very first image, with the C-arm rotates around the patient with contrast injection to show that we really got our coils right at that pocket. So this is something that, because we have been doing all these imaging in the OR, we were able to kind of push the envelope and do this and save this patient from a potential redo surgery.
And she's now a year out, so it's not just show and tell in the short-term outcomes. Yeah.
And this is something that Dr. MacGillivray, we have been working on to how we make use of the CT data set. For example, what I'm doing here is peeling the skin off, fading in the bony landmark, and kind of helping with where the Lee-modality bypass is. So how would you use this? Say if we show this case for tomorrow, how would you change your approach?
Well, so I mean, we have all this precision imaging, and then we go and cut the patient wide open. You know, it's
Right.
so ideally, I mean, the holy grail would be to use this precise imaging to have surgery that's more precise.
Yeah.
To directly answer your question, one of the great concerns we have in people who've had previous bypass surgery is the left internal mammary artery can be almost anywhere, and it's hard to know where it is. One place you don't want it to be is in the crosshairs of your saw, because that can make the difference between, I mean, the mortality from that is high, and even if the patient doesn't die, if you lose that internal mammary artery, you essentially take away the benefit of that operation in terms of long-term survival. So being able to know exactly where it is and exactly where it isn't is very, very helpful in the planning of a reoperation.
Okay. So now we are talking about taking this data, rich data that's already there in the CT, and using it for open surgical planning. Right. And we don't have all these fancy hybrid imaging equipment in these open operating rooms. So for example, here we have 3 hybrid ORs and maybe another 12 open rooms. So what we are looking at is how we can get this data or information from CT linked to the surgical view or the surgeon's hand. So in a way, it's kind of like, instead of you scrubbing out and looking at the image in a PACS PC, how we can enable you to interact with these images from the surgical field, preferably in a sterile environment.
But how is it done? Talk us through what we're looking at up here.
So what we are looking here is there are 2 ways. You can kind of take a regular a scalpel or something, any tool, and put an electromagnetic sensor or a gyroscope, just like what we have in all our cell phones, and use that to register this patient, which is kind of what we are showing here, is you're kind of registering.
So there are certain bony points or points that you're saying, this is, so for example, left nipple, this is xiphoid.
Yeah.
How many points do you need?
So roughly you need to create a surface, so you
Yeah.
need at least more than 3, preferably. The more the points, it's better, the accuracy of registration is. But again, if you are trying to link it to just to kind of have a rough idea of how you plan your incision, you don't need that many points. So it's kind of a good balance between creating a surface and then matching the pre-procedural CT to another surface that we create with no x-rays involved here. So this is another way of bringing preoperative planning to your open operating room. And there are even other platforms such as AR, VR, or mixed reality platforms. And there are more and more of these solutions that will be out there. So you can eventually, I personally foresee that those will be the framework that I was talking about in an open operating room, where within a few seconds you'll be able to pull the CT or MR or echo images of that particular patient before you even do your first incision.
And the visualization's an iPad equivalent that you can hold over the chest and be able to say that's where the lima is.
Yeah.
Make cut here.
So we can link it to the tool, or we can link it to some kind of like a AR platform, or we can just use any kind of like a window, like a iPad type display.
And the nice thing, this would be a fraction of the cost of a hybrid room.
Yeah.
Right.
Yeah.
And we are very early in this project, but again, it is promising, and the impact here is much more than some of the standard way of planning for these surgical procedures.
Must be great for minimally invasive direct coronary artery bypass.
Yeah.
Absolutely.
Exactly.
Yeah. Yes. Absolutely.
So, and kind of switching gears towards thoracic surgery, you can not just do vascular procedures, you can also target a lung nodule. So this is all done in one setting with the patient coming directly to the hybrid OR. Most patients often have a CT because of the CT screening protocols now active for lung cancer. So once you know the patient has a nodule, the patient can come directly to the OR. You do your 3D scan. Nowadays, these 3D scans can be done even with a mobile C-arm. So you acquire a 3D image or a cone beam CT, and you see the nodule, and you target a needle, put a hook or a coil or ICG or methylene blue target, and then you do your minimally invasive VATS. So all imaging, targeting, and navigation and surgery all done in one setting. So patient leaves pretty much the same day if everything goes well. So this is one other way we can kind of streamline all these. So what I'm showing here is not just applications, but the workflow of how you get from point A to point B. And this is another example for endoleak from after EVAR, where we thought that the easiest way to kind of get it is from an anterior approach. We use laparoscopic guidance and a combination of image guidance, directed a catheter into that particular posterior aspect of the sac, and then here you can see us putting in coils, which is matching exactly with where the endoleak was from before. So this is another example of how you can use imaging. So kind of to sum it up, yes, we have tools to do the fusion, whether it is open surgery or endovascular surgery. But still, one of the common challenges is how do you seamlessly work in these CT data sets and extract the content. What I mean by content extraction is image segmentation, which is a technical term, but from a surgical standpoint is the CT data has thousands of structures in it, but how do you make sure you extract and quickly get that information? So this is one of our aortic coarctation patient who had bucket handle repair, and we kind of optimized our views, and we fused this patient, and we deployed a stent right across that tight narrowing that we see here. And this is again one of the patients with Dr. Huey Lin, who I work with here, a complex coronary artery fistula, where we were able to put some coils from a purely endovascular approaches. So the point I'm trying to make here is, if you have the 3D data set, you need some set of skills to get to that information, but as a company, we are working towards how we can make that process quicker and automated. And now I'm switching gears from 3D to 4D. And these are some of our early examples. So by 4D here, I mean the time component. So here it's a gated scan showing a type A dissection here that's extending all the way into the descending thoracic aorta as well. And this is one of our dynamic CTs showing endoleak of blood coming from L4 vertebra, flowing inside the sac, and then washing out into the L3. All this information is there. So in my opinion, the diagnostic imaging is still the best from CT or MR, and we shouldn't be using our precious OR time to make the diagnosis. So most patients who get a CT image or an MR image, the protocols has to be optimized enough to understand the underlying clinical question that the surgeon or the interventionalist is looking for, and then when we take the patient to the OR, we are in this phase of executing our plan, right? Most often where we spend a lot of time in the OR is trying to find the diagnosis, especially in endoleak cases where most people get inside the sac and we are shooting multiple pictures, selective angiograms, and then trying to see where it is filling.
You're saying we can figure all this out beforehand?
Yes, absolutely. And that's kind of, we have done maybe close to 25 patients now with these dynamic CT, and we're also doing a little bit more MR as well to map out these endoleaks for intrarenal aneurysms. And I'm hoping we don't see this as many with the newer stent grafts, and even moving into the thoracic space or even branched endografts, where it should be very critical to differentiate between a type 1 versus type 2 in presence of all these complex constructs that we are putting in these patients.
So you can't take him to Sugarland, Marvin. So we thought about putting a black hood over his head with little eyes and then changing his voice so he doesn't get stolen away from us. But pretty impressive.
It was impressive. You know, it reminds me of, when I was a kid, my dad was a general surgeon.
Mm-hmm.
And one of the most common operations they did in those days was an exploratory laparotomy.
Yeah, that's right.
Make a big incision to try to figure out what was wrong.
Mm-hmm.
And in many ways, in open surgery, we still do that.
Mm-hmm.
We do have imaging, but a big part of the surgical planning is going in there and figuring out what's wrong. With these tools, as you pointed out so elegantly and so beautifully with those images, that you can figure out exactly where the problem is and focus your attention and your procedures on that particular point.
So let me finish off with one of my favorite topics is visualizing flow. So far we have seen time, morphology, but we have not seen flow, so especially in big vessels like this. When I see images like this, it just kind of puzzles me, because we really, especially in a case like coarctation or aortic dissections, for example, we, at least in my mind, we do a good job of doing the morphological imaging, but we still don't, from a pathophysiological standpoint, understand the complexity of the flow patterns in these patients. So, for example, if I switch the display here for a quick second, so this is a different patient, not the patient we treated, who had a type B dissection, and here, as I am rotating around, we can see the complex flow patterns. Again, there is a lot of information here which we have to unload. But what we are looking here is the flow across the aortic arch, and what you see here in red is, let me freeze.
So let me, because you and I talked a little bit about this. What exactly is it we're looking at? There are lines in there, and each one of those lines represents what?
So you can think of this as particle tracing. In MR, you can image in X, Y, and Z planes. And every pixel, when across different cardiac phases, when it is maximum opacifying and when it is not. So using that information from multiple planes, so this is a technique called phase contrast imaging, which is done in 2D planes and then reconstructed in 3D. So it's kind of like how we do 2D DSAs and rotate the C-arm and get a 3D picture. In MR, it is acquiring data in multiple planes and putting it together in 3D. So all this coloring here, the color bar here is showing centimeters per second, it's velocity. So you are looking at flow patterns and with its encoded velocity in the true lumen, and what you are seeing here in filling in blue is the low velocity flow in the false lumen. And why this is important? So here you can see from the true lumen there is some flow going into the false lumen. How do I know that? Because I've studied this data set by looking at the morphological image and also across different time points. And here, so why is this relevant? It's not just a fancy picture where we can look at it. It's definitely nice picture, but in addition to this could be done, this takes roughly 15 minutes to do the acquisition. It takes time, like in MR.
So you have to, when you order it, you have to ask for 4D flow. We've got it set up here It's a little bit, can the patient tolerate it? How long has the patient been in the scanner? But if the patient's doing okay, they'll add this onto the back end of the study. But you're not going to get it automatically. You got to talk about specifically about getting 4D flow.
And how much longer does it take?
About 15 minutes. Yeah.
15.
So here what you're looking at is the true lumen and the false lumen that I was talking about, and that's the left subclavian, and all this color here, information here, is the flow pattern. So it also gives you an idea of directionality of flow. And if you want to really quantify, for example, so here you can draw a region of interest and create a flow curve. For example, you can measure the flow in the true lumen and the flow in the false lumen. So, and all I'm pointing out here is from imaging, we can be much more quantitative in these physiological, especially in aortic dissections, where we can measure the flow in these true and false lumen.
Now, does that correlate with shear stress or wall tension at all?
There are studies. So this is still kind of under research. Most of the, but people are still using it. So instead of going ahead and doing CFD, where we are assuming random boundary condition, this data serves as an input to figuring out, is it worth intervening in the false lumen for this patient, or is this going to rupture? So all these wall shear stress can be derived from this data. So yes.
Yeah. So just to drill down on Marvin's point a second. So what you mentioned particle.
Mm-hmm.
So is the particle a red blood cell? Is the particle a velocity? Is the particle energy?
Yeah.
What exactly is it?
I think we are deriving that from the pixel values. So we are looking at blood flow. So that's essentially what it is.
Not
So
Farahim or
no.
So it's a volume.
It's a volume.
It's a volume,
Yeah.
but inside that volume are what, red cells that are moving.
So I mean, I'm not an expert in this, but I see a lot of value in kind of at least doing this systematically, especially in patients who undergo surgical repair. Then there is no metal hardware in them. And for example, one of the studies that came from Northwestern is the helical flow pattern in the ascending aorta. So as we know, the LV is not just like pumping like in a mechanical wall, it twists, and that creates a helical flow pattern in the ascending aorta. So what happens to that flow pattern if you suture a Dacron graft, right? And people have shown that it's very hard because of the lack of capacitance in the Dacron graft as much as compared to a human tissue. You don't get reproduce that flow pattern. But what is the end effect of that? We don't know, because we need more long-term studies, especially pre and post surgery in these patients, to really understand not just, okay, we put in a tube graft or we recreate it, that's great, but still we wanted to know what is the downstream effect over a few years of doing our surgical operation.
I mean, just to put this into, I mean, these are very beautiful pictures, but to put it into context, as I say, in this case, coarctation, it's the most complicated, simple problem that we have, right? It's a small little narrowing that you'd think that by cutting it out or putting a stent graft in it, you'd fix it.
Yeah.
And time has told us that that's not really the case. We have a pretty blunt instrument in terms of how we follow aortic disease right now. We follow size. And that really, we're learning more and more now that really doesn't help us predict dissection. It doesn't really help us predict rupture. It does if you look at 10,000 patients, but for that specific individual patient, how do you make a decision of when and what kind of intervention is necessary? And these are the kinds of images that hopefully will help us solve that problem.
So the point I'm trying to make here is imaging can definitely get us that information, but we need to do our studies in these patients, especially long-term studies if we are trying to understand individual rare pathologies, or if you're talking about ascending aortic repair, for example. Most patients get Dacron repair if they come in with type A dissection. So those are the patients where we could get pre and post MR images, so preferably at least post MR images, and then try to understand this much more from a physiological standpoint. That's the message I'm trying to deliver here. And that I just kind of wanted to summarize
Right on time, as
Yeah.
always, Ponraj. 6 o'clock.
Summarize it with,
Yeah.
so this is definitely an evolving field with multimodality image guidance, especially in hybrid operating rooms. By hybrid operating rooms, I don't restrict only to fixed C-arms. It could be any imaging. So even an open operating room can benefit from all these advanced imaging. And definitely, more often the emphasis has been focused on the overlay and all these fancy lines that we put in. I would say the focus always is often better, and the return on investment is more if we start thinking about how we optimize our diagnostic imaging for the underlying question that we are trying to answer. And
That sounds like a topic for another evening. What do you think? Well, thank you all very much indeed. We're a little bit over time, but I'm blown away. That was very
Thanks a lot.
Thank you very
Thank
much
you.
for
Thanks very
allowing
much. Yeah.
me to
Thanks,
share
Alan.
what I have explored so far by working with you guys.
Great. Thank you.
Maybe just talk to one another for a couple of minutes as they go off camera.